Today, as advertised, I'll be talking about testable, scalable, IVR-supported physical activity interventions in the Black Belt. All right. And just to give you an overview, we'll start with some background on physical activity, what is the Black Belt, interactive voice response systems. Then I'll move on to discussing the formative research we conducted in developing interactive voice response systems supported physical activity interventions for cancer prevention in rural Black Belt counties. We'll talk about the focus groups and a pilot randomized controlled trial. Then we'll move on to the current project. It's a 5-year National Cancer Institute R01 funded randomized controlled trial. And it is ongoing. All right. So we'll start with background. Despite the cancer protective effects, rates of physical activity are very low in the US, particularly in the Black Belt region, where related cancer incidence and mortality rates are generally higher than seen nationally. Many people ask, what is the Black Belt? And I use this term often in this talk, so I'll go ahead and define it. It's a rural region of central Alabama and northeast Mississippi. Black Belt, the name actually refers to the dark, fertile soil. This area has a history of cotton plantation agriculture back in the 1800s. There are also a high percentage of African-American residents. Physical activity interventions are really needed in this Black Belt region, but they're often barriers. For example, there are lower literacy rates than seen nationwide. There are high rates of poverty, and there can be issues with transportation and technology and distance from facilities. These are very spread out geographic regions. So when I first started at UAB, around 11 years ago, did a series of ACS funded, ACS is American Cancer Society, funded focus groups to learn more about the physical activity intervention needs and preferences in these counties and these communities. So we did 11 focus groups with Deep South Network for Cancer Control, community health workers, and residents from rural and urban counties. We met with these participants in church halls and public libraries. And it was a very interesting experience, just wanting to hear what people wanted from a physical activity program and what would be helpful, what kind of resources were needed. Often these interviews, the facilities weren't air conditioning, there was no Wi-Fi, there was no cell phone connectivity, but the feedback was really helpful. Some of the barriers and preferences that participants talked to us about were pretty anticipated. We heard things like there are no health clubs out in the country. And, kind of pinpointing that there's an issue with access to safe and affordable means to be active in some of these rural counties. Some of the participants made comments such as, if you don't have the money to pay the light bill, then you don't have the money to join a health club. And pinpointing that cost were an issue. And that, kind of a hierarchy of needs. Okay. Other barriers and preferences were less expected. For example, participants would remind me that it's not just the Black Belt. We're in the Bible Belt here. And a lot of the participants said that this is an area with high rates of religiosity, and that this religiosity needed to be incorporated into the intervention and acknowledged, taking more of a holistic approach to health and wellness. There were also built environment concerns. Many of the women expressed worries about being run over due to lack of sidewalks. And, I recently was out walking in Lowndes County and had to jump in a ditch to avoid an 18-wheeler. So, I can say firsthand that some of their concerns were well-founded. we started talking to them about telephone-based interventions. We were hoping to overcome some of these barriers because telephone-based interventions don't require travel. You don't have to drive that hour to the nearest city to visit an exercise facility. It avoids expensive technology such as computers. And it also gets around the literacy issue, you know, if you can present information orally. One hiccup was there's not really enough staff or money in some of these rural counties to offer kind of physical activity phone counseling. Like that would be a limiting factor. So we started looking into interactive voice response systems as a method to automate this telephone counseling to further improve its reach and cost effectiveness. Luckily, there was an IVR system already up and running in health behavior. It was being used in addiction studies. So part of my early work was adapting it for individually tailored theory-based physical activity counseling and using my focus group research to kind of inform that process. This led to the DAO study. The first one, this was a small RO3 from NCI to test the feasibility and acceptability of the resulting interactive voice response system supported physical activity intervention for cancer prevention. We conducted a pilot randomized controlled trial of what we call the Deep South Interactive Voice Response System, active lifestyle intervention versus a waitlist control with 63 individuals here in Birmingham. Basically just to test, kind of test the bones of the intervention with a convenient sample. And we conducted assessments of physical activity and psychosocial variables at baseline and 12 weeks. The intervention was guided by social cognitive theory. And how this worked for DIAL was we targeted the key constructs such as self-regulation through this intervention. And some of the strategies for self-regulation were having participants wear pedometers and track their steps and moderate to vigorous physical activity through daily interactive voice response system calls, in which they would get feedback on their progress and their steps on the calls, and they would also get a monthly graphic-based report. And they also get monthly monetary incentives for self-monitoring, not for steps. But there was a behavioral economics piece where they would actually get paid a quarter for calling in and reporting their steps each day. And if they reported their steps for 7 straight days, the amount increased to 50 cents. And it stayed at 50 cents until they missed a day, and then it would go back to a quarter. And over the 12 weeks, they could only really earn up to like $43.25 through this behavioral economics approach. And they enjoyed it. They kind of gamified self-monitoring and self-regulation. And the participants got really intense about their quarters. So some examples of our phone counseling messages that participants would receive. If they reported meeting the National Physical Activity Guidelines, they'd receive a message like, you're on your way to meeting the national guidelines. Keep up the good work. Consider leaving yourself reminders and finding a walking partner to help you reach that goal. All right, we also targeted constructs such as self-efficacy, social support, outcome expectancies, and enjoyment. They're also pretty key in social cognitive theory to behavior change. And for strategies for this would be participants would receive individually tailored IVR supportive phone counseling at 4, 8, and 12 weeks, which was specifically tailored on those variables. So for example, if they reported enjoying physical activity, they'd get a message like, you enjoyed physical activity, more so today than the last time we spoke. That's great. Try exciting new activities like Tai Chi or kickboxing so it stays fun. And we had, we built a big message bank full of any possible outcome of response to inform these tailored responses. For the pilot study, in terms of demographic characteristics, participants were 43 years old on average, and the mean BMI was over 30. A majority of the participants were male and African American. We were pretty excited to get such good representation for men. So I hope this happens in the fully powered randomized control trial. Most of these participants reported at least some college level education, full-time employment, and household incomes under $50,000 per year. So maybe a little more education than we might expect in rural counties. We will see. So retention was high at 12 weeks and did not differ by group. Most intervention participants showed pretty adequate adherence. 63% completed at least 63 daily IVR calls for physical activity tracking. That's about 75% of the required daily calls. And then 78% completed at least 2 of the 3 required monthly counseling calls. So pretty decent adherence. In terms of satisfaction, of the intervention participants who completed the participant satisfaction survey, most were satisfied with the DIAL program and would recommend it to a friend. Participants reported that they wore the provided pedometer often and called into the DIAL study line at least a few times per week. And moreover, most participants found the DIAL line easy to use. In terms of changes in physical activity and related variables between baseline and 12 weeks, the DIAL participants reported larger increases in minutes of moderate to vigorous physical activity from baseline to 12 weeks than the control arm. We're talking immediate change of about 47 minutes per week compared to 5 minutes per week. Interestingly, accelerometer data indicated no significant changes between or within group. We were only able to get accelerometer data at both time points from like 9 participants, so that was an issue. In terms of results, trends in the data indicated that intervention adherence resulted in greater physical activity. For example, DIAL participants who called the IVR system for the required 84 days reported almost 20 more minutes of moderate to vigorous physical activity at 12 weeks than those who called less than 84 days. Okay, and DIAL participants who completed the 3 required monthly counseling calls reported, almost 35 more minutes of physical activity at 12 weeks than those who did not. So there definitely seemed to be a trend there. In terms of changes in psychosocial variables between baseline and 12-week, we did see that the DIAL intervention participants reported significantly greater increases in physical activity self-regulation, family and friend support for physical activity, and a reduction in exercise barriers compared to the control participants. I also thought it was kind of exciting, since we had a waitlist control in this pilot study, that we were able to show some exciting preliminary efficacy, and then we were able to replicate those findings in the waitlist control after the original intervention group was done. They also showed increases in physical activity after a 12-week intervention dose, and reported high program satisfaction and similar adherence to the IVR call protocol. Okay. In terms of conclusions, the results supported the feasibility and acceptability of the IVR supported physical activity interventions for the Deep South. But this was just an early step with a small community sample here in Birmingham, Alabama, which isn't the same as rural populations, and automatically just we very quickly picked up that we're going to need to conduct some intervention refinements in response to pilot data and participant feedback that we gathered during this pilot trial before we rolled this out in a larger randomized controlled trial in the rural counties. Some of the technology and theory refinements that we made in response to this feedback and to our findings, our pilot findings, where we realized there was a trend in the data that self-monitoring your physical activity, completing these calls is helpful. There definitely appears to be a trend. So let's make adherence easier. And then we did conduct exit interviews with our participants, and they repeatedly kind of hinted that they were having to initiate these calls each day. And at first we thought that would be great because it'd be convenient and they could make these calls when they wanted to. But the impression that we were getting was for a lot of participants, it was burdensome. And it was difficult to remember to make those calls. And so in the newest iteration, we decided, let's make adherence easier. We can have the IVR system initiate these physical activity tracking calls so participants don't have to remember to do so. Participants also called for more encouragement and accountability. One participant just spelled it out how she wanted us to set very specific adaptive goals for each week for her steps and how maybe they need a little more support. So there is an existing support network through the UAB Comprehensive Cancer Center Community Outreach and Engagement program. They have county coordinators spread all through the these rural counties. And so one thought was, if they want more encouragement and accountability, we should tie in this county coordinator support. Okay, we also noticed that we didn't change all the key social cognitive theory constructs that we had tried to target with our intervention. And so we made a concerted effort to kind of further address those that didn't change in response to our earlier intervention iteration. And participants, like I mentioned earlier, we did see improvement in physical activity barriers as a result of this program, but no change in benefits. And so we recently published a paper on this. And one of the things we were considering is we need to provide more information on physical activity benefits. And a lot of participants just told us that they would like to be reminded more about what they can get from an active lifestyle. So we definitely added that to the intervention. And then we realized this was a good individual level intervention, individual level physical activity counseling with social cognitive theory. That's an interpersonal level. You're talking about the immediate kind of social environment. And then if we brought on county, coordinator support, we're kind of getting that community level. But to really take a social ecological perspective, it would be great to learn more about the neighborhood and environmental features that hindered or facilitated physical activity in these rural counties. So one next step would be to assess the neighborhood and environmental features that also play a role in our health behaviors. Okay, so the follow-up grant titled Testing Scalable IVR Supported Cancer Prevention Interventions in the Rural Alabama Black Belt. This R01 began in June 2019. We also call it the DIAL study. And this time we are testing the efficacy of a 12-month refined DIAL intervention plus county coordinator support compared to a waitlist control condition in rural counties. And our hypothesis is that the DIAL intervention will produce significantly greater increases in physical activity from baseline to 6 and 12 months than the waitlist control. There are numerous exploratory aims. We're interested in intervention effects on physical performance and psychosocial variables. I'll elaborate more on this later. As well as long-term physical activity maintenance. It's really exciting to see short-term changes, but they're probably not conducive to those health benefits that we really want to see. So now we're going to look at 6 months post-intervention improvements in physical activity for the DIAL arm, and those kind of replication of findings in the waitlist control. We're also tracking intervention calls. We'd love to roll this out through, rural counties, and just keeping in mind dissemination, implementation potential. We need to know how much this cost. All right. We'll be examining potential mediators of the social cognitive theory constructs that we're targeting through the intervention, and moderators, age, gender, of treatment efficacy. And then we'll also be looking at barriers and facilitators to taking this intervention and just widespread implementation through the Black Belt by UAB Comprehensive Cancer Center, community of outreach and engagement. Taking their county coordinators and making this just a tool in their tool belt, like what would get in the way of that, how could we help, and kind of seeing how this fits with them. All right. In terms of the design of the study, it is a randomized controlled trial of a 12-month refined dial intervention. This time, the recruitment, intervention orientation, and assessments are led by the local rural county coordinators from the Cancer Center Office of Community Outreach and Engagement in the rural Black Belt counties. And the assessments of physical activity and related psychosocial variables will occur at baseline 6, 12, and 18 months. All right. Participants, we are recruiting 240 underactive adults from Hale, Choctaw, Greene, Marengo, Dallas, and Sumter County. So that's 6 counties with the goal of about 40 a county, to kind of minimize recruitment burden on any one particular county. We had a lot of plans about what recruitment would look like before coronavirus, but at this point, it's involving distributing study flyers through social media, email, we've also turned to local newspaper advertisements. We haven't done any radio advertisements, but if we need to, we might look into it. Our eligibility criteria for this trial is over 18 years old, insufficiently active, under 60 minutes per week of moderate to vigorous physical activity. Obviously, we're looking for residents of the participating rural Black Belt counties with no serious medical conditions that would make physical activity unsafe. We're using the PAR-Q, the physical activity readiness scale, to assess for medical eligibility. So we're looking for issues like, history of heart attack or chest pain. And we also need participants to be able to regularly access a telephone. So it can be a work landline, a home landline, it could be a cell phone, but they need some kind of phone access to complete IVR calls. And the ability to use landlines in rural counties is important because there's still areas where it's hard to get good reception. Okay, so in terms of the protocol, participants complete a telephone eligibility screening interview, and they learn a bit about the study. Then they're scheduled for a baseline assessment and randomization session in which they do actually come in, get weighed and measured, and do their physical function test. Now they are completing their measures. We mail them their measures and have them turn them into us. And we're trying to do as much as possible via distance, like telephone, mail, but we're trying just to get them in face-to-face only for 15-minute sessions to limit any COVID exposures. Okay, the enhanced dental intervention, like I mentioned earlier, it does combine county coordinator support and the IVR automated physical activity phone counseling. So participants get regular automated calls on a daily basis in months 0 through 3, then twice a week in months 4 through 6, and then they receive weekly calls in months 6 through 12. All right, there are 3 types of IVR calls that participants receive. They receive physical activity tracking calls where they wear their pedometers, report their steps and minutes of physical activity very quickly. And that's about a 2-minute daily call that they complete. There's a social cognitive theory-based physical activity counseling call. This is a monthly call. It's where they get a brief assessment and tailored feedback on those key social cognitive theory variables. And then there's a new feature, is an adaptive goal setting call, which they receive weekly throughout the study and kind of encourages participants to gradually increase their physical activity towards 10,000 steps per day, with letting participants set those incremental goals and are, just encouraging 500 extra steps a week. All right. This refined dial intervention is one of the things we took to heart was making it more interactive. So we've transitioned to Twilio cloud communication platform to support a bidirectional call format. So in the pilot study, participants were able to initiate the calls. And in some of my other IVR studies that I've worked with, participants only receive calls. But after I've been involved with a few of these studies, realized it's pretty important for them to be able to automatically receive a call, but also be able to return a call if they want to, and be able to kind of have that flexibility in call format. We also switched to Amazon Polly for narration instead of having research staff narrate the counseling messages. It's much clearer and crisper, like the sound quality is really great. And initially I was kind of concerned that it would sound too robotic, but it's been very well liked by our rural county coordinators. So we're also having a little fun with randomly assigning participants to IVR call voice condition. They'll either be matched by gender or receive like gender, opposite gender voices, or a random gender voice. We're kind of interested in exploring the differences in outcomes by gender matching of IVR counseling voice. Does the, in the clinical literature, there's a lot of talk about matching of therapists and patients. So it's kind of interesting to see how that works when technology is involved. In the pilot study, we did not have a problem much with adherence or engagement because it was only a 12-week study, but now we're shooting for a year. We're really trying to get long-term outcomes, long-term physical activity gains. And we had to keep in mind the content needed to vary to keep them engaged over that long period. So we have a bank of different welcome messages and voices to keep it to where things stay fresh and it's not always the same every call. And we've also developed tips of the week. That's a feature where participants hear different ways each week on how to get more steps. It talks about barriers to being physically active, such as not enough time, lack of support, lack of enjoyment, negative expectation, cost, fear of injury, the things that came up during the formative research with this community. And we also have IVR, kind of rotating IVR modules on benefits to being physically active now. So physical health benefits to exercise, mental health benefits, chronic disease prevention benefits, productivity benefits, and even social benefits. Okay, like I mentioned, another new component is that county coordinator support. Now, this is a piece that has really changed given the pandemic. Our goal was that the county coordinator would help get the local participants who were interested in local walk groups connected and walking together and kind of support and organize those aims. But we obviously have had to do some rethinking. At this point, what we've set up is there are brief problem-solving calls that each participant will receive at months 3 and 9, just to kind of keep them connected, through the phone, let them know that there are real people at the other end, remind them that their coordinator is there to help them, and they'll also get progress feedback from their coordinator at those brief assessment visits. We've also had some fun since we can't do the local group walks. We've pushed this back to the coordinators and made this a challenge to them. How would you like to kind of unite your community and get them more active? So right now, our first county is Dallas, and the Dallas County coordinators are doing a dance challenge where they are working on dance videos and challenging their participants to, recreate the dances, and they'll have like monthly dance video challenges. So it's, keeping that up. And then in the next county, we'll talk with their coordinators and let them kind of guide us what they think might be a good way to build community around physical activity in a, pandemic safe way. We also have monthly study newsletters. So the first one is just about to go out. And the first one is kind of an introduction to physical activity resources in their community, as well as, an interview with their county coordinator. And, they'll be tackling different physical activity topics each month. The waitlist control, they attend monthly UAB Comprehensive Cancer Center community outreach and engagement Zoom meetings on topics other than physical activity, and they'll also get their own study newsletter. And then they'll receive the same 12-month DEL intervention after 6-month assessment. We're still hoping to replicate findings in our waitlist condition in this study also. Okay, for assessments in the randomized controlled trial, participants will complete a 7-day physical activity recall, a golden leisure time exercise questionnaire. They'll all wear accelerometers at baseline 6 months, 12 months, and 18 months, as well as complete 2-minute step tests to gauge physical function and receive all the usual anthropometric measures: height, weight, waist circumference, blood pressure. Okay, in terms of surveys, we're going to be measuring social cognitive theory constructs at every time point: baseline 6 months, 12 months, 18 months, as well as intervention cost and exercise barriers. Also, anxiety, depression, fatigue, and sleep disturbance. We did see an improvement in sleep disturbance in the pilot study that we'd like to follow up on and see if we cooperate in this larger trial. We'll also have participants wearing their accelerometers on their wrist at night, so we can see if we can get some more objective data to corroborate the pilot study findings on sleep disturbance. I'm also really excited to be studying resilience and self-compassion in this study. I think since we're looking at physical activity maintenance over the long term, and we still haven't figured out what it takes to help people maintain a health behavior over the long term. But there's a great psychological literature on resilience and self-compassion. And qualitatively, I've been working with participants in physical activity randomized controlled trials for a very long time. And what I typically hear when I'm calling a participant who's kind of fallen off and their engagement with it and adherence isn't so great, I hear a lot of I've let the study down. I'm not doing a good job, and I'm just messing it up. I should just quit. And kind of, if they can't do it 100% perfect, they beat themselves up. And I'm almost wondering if resilience and self-compassion play a role in maintenance. And I think if we could demonstrate that, those are skills that could be built and incorporated into interventions and may play a role in kind of long-term health behavior change. We'll also be looking at participant satisfaction and stakeholder acceptability. We're going to interview and administer surveys to the county coordinators on the ground, as well as the infrastructure. in the different counties and through the Cancer Center about, did this work, and what about this program worked, what didn't, what would need to change before further dissemination and implementation. Also, we'll be conducting rural active living assessments to gauge built environment and walkability in each of these rural counties. And this will help inform future built environment and policy directions, kind of give us that data that we need, to improve those aspects. Despite coronavirus and research shutdowns and definite pause over the summer, we have almost completed our startup activities. We've been very lucky to get staff hired and trained, and we were able to purchase a lot of equipment before the shutdown. So we spent a lot of the shutdown kind of overhauling the interactive voice response system with Dr. Mohan Thiramalai and his team of computer programmers, just testing and retesting and really working on that and fixing it. We even were able to conduct a focus group with the county coordinators on kind of to inform these intervention refinements. We wanted to come back to them and run some of the refinements by them before we proceeded. Okay. The shutdown even allowed us to conduct some usability testing of our newly refined IVR system. So what we did over the summer, we got 10 of the rural county coordinators with the Cancer Center and some other research staff, and we ran them through a 2-week trial, just a single arm trial of the IVR system, with the hopes that this opportunity would allow them to kind of catch glitches in our interactive voice response system before the larger randomized controlled trial, and also to help the staff gain familiarity with the inner workings of the IVR system so they could better field questions from participants when that came up. So we, after their 2-week trial, we administered usability surveys and qualitative interviews. So here you can see we've already kind of tabled the usability testing survey results, and overall, participants, they thought the system was pretty good, but it wasn't unanimous, right? When you see questions like, I think I would need the support of a tech person to be able to use this system, 70% agreed. Wait, 70% strongly agreed, but 30% somewhat disagree. There were some things that weren't quite coming out, like the usability, the survey data was saying, we like the program's pretty easy to use, but it wasn't unanimous. Some people were holding back. So the good news is we were able to follow up with qualitative interviews and kind of shed some light on some tech issues and some wording issues in our intervention material, in our IVR system. For example, we had an issue with the phone system would hang up on people for a while, or it wasn't calling at the right times. And we were able to figure that out. And then we also we didn't realize some of the intervention messaging would be repeated so often, and it was actually kind of negative and demotivating. So we were able, with their help, to identify that and address that situation. And we've already made a good bit of related changes to the IVR system, and we're continuing to sort through these transcripts. There's a lot of gold in them. It's been very helpful. So we began recruitment for the larger trial in Dallas County in August 2020. We screened 52 individuals for eligibility and enrolled 46 participants on September 8th. We've been wrapping up their baseline assessments, getting back the accelerometers in the time of coronavirus with everything going through the mail and, some minor mail delays we've been experiencing lately. That's taken a bit longer than we might have expected. But we're conducting, we've already conducted the rural active living assessment for this county, which is really exciting. And then in October, we are hoping to move on to Sumter County, move on to our second county. We're trying to stagger it so we can take the lessons we learn from each county and apply that newfound knowledge in our next county. Just in terms of discussion, these IVR supported physical activity counseling strategies have great potential for overcoming physical activity barriers and reducing related cancer disparities in the Black Belt. I think there's a lot of potential here, and we're always looking for collaborators. We should think broadly, and that interactive voice response systems could be used to address, they actually reach people and people are willing to participate in them. And these approaches could be used to address other rural health issues here in the Black Belt. So, and just to throw a pitch, this R01 would be a great opportunity for a supplement, should anyone be interested in collaborating on that. All right, and just would like to take the chance to acknowledge funding from NCI and from the American Cancer Society and all the great collaborators here at UAB. You have both faculty and staff, and most importantly, students. And we also have collaborators at Arizona State University and Brown University who've been instrumental in moving this research program forward. It takes a village. But most importantly, the thanks go to our county coordinators. They're the ones out in the field kind of making this happen in the rural counties. And so here's a picture of some of the county coordinators at one of our training sessions over the summer. No, this was before coronavirus. We're not wearing masks.